Cervical cancer, also known as cervical carcinoma, is the third most common malignancy in women. And it is a leading cause of death for women in developing countries. In developed countries, however, cervical cancer is relatively uncommon due to the availability of screening programs. Cervical cancer is caused by persistent, high-risk, human papillomavirus infection, which is a double-stranded DNA virus, of which there are more than 100 different types. Approximately 70% of the cervical cancers are squamous cell carcinomas, while most of the remainder is adenocarcinoma. The virus is transmitted via sexual intercourse, and therefore it is more prevalent among the women of reproductive age. Before we begin our discussion on cervical cancer itself, let's quickly recall some anatomy knowledge on the female reproductive system. It consists of 5 major parts. Vagina, which allows deposition of sperm during sexual intercourse, cervix, which continues proximally with the uterus, the muscular organ that implants the fetus. Fallopian tubes, which transports the sperms towards the ovaries, and the ovaries, which produce egg cells that contain the maternal half of the fetus. Out of these, cervix is the part that connects the vagina and uterus in order to transport sperm cells. Anatomically and histologically, the cervix is distinct from the uterus, therefore it is considered as a separate anatomical structure. The cervix is composed of 2 regions: the ectocervix and the endocervical canal. The ectocervix is the portion of the cervix that projects into the vagina. It is lined by stratified squamous non-keratinized epithelium. The opening in the ectocervix, the external os, marks the transition from the ectocervix to the endocervical canal. The endocervical canal, or endocervix, is the more proximal and inner part of the cervix. It is lined by a mucus-secreting simple columnar epithelium. The endocervical canal ends, and the uterine cavity begins, at a narrowing, called the internal os. When we examine through the vagina, the ectocervix and endocervix look like this. The cervix is approximately 2.5 centimeters in length. The upper part of the cervix mostly consists of involuntary muscle, whereas the lower part is mainly fibrous connective tissue. The epithelium of the endocervix is columnar and is also ciliated in its upper 2/3. This changes to stratified squamous epithelium around the region of the external os, as you can see in this picture, and the junction of these 2 types of epithelium is called the squamocolumnar junction. Position of the squamocolumnar junction varies throughout life. The area between the original squamocolumnar junction and the current squamocolumnar junction is called the transformational zone, and this is the site where cervical cancer develops. As already mentioned, cervical cancer is caused by human papillomavirus infection. More than 100 different types of this virus have been identified. These are classified as low-risk and high-risk types, depending on their ability to cause cancer. Low-risk types, HPV 6 and 11, cause benign warts, whereas high-risk types, HPV 16, 18, 31, 33, and 45, cause cervical cancer. In most individuals, the infection is transient and no clinical consequences occur. However, in a minority of individuals, the infection is persistent and there is a higher risk for cervical cancer. Risk factors for persistent infection include smoking, immunosuppressive therapy, and conditions that cause impaired immunity, such as HIV infection. When HPV infection persists in certain individuals, it triggers an oncogenic process in the region of the transformational zone. Integration of viral DNA into basal epithelial cells leads to immortalization and rapid cell proliferation. This process is called cervical intraepithelial neoplasia. And it is important to note that this is only the metaplastic state and not the cancerous state. It may or may not progress into cancer. In this image, the leftmost side diagram shows a normal cervical epithelium. 3 diagrams in the middle show different stages of CIN. In all of these stages, the basement membrane is intact. Therefore, CIN is considered as a precancerous state rather than a cancer. The diagram in the rightmost side shows cervical cancer, where the basement membrane is breached. Stage 1 CIN indicates low-grade disease, whereas Stage 2 and 3 CIN indicates high-grade disease. If the basement membrane is breached, it is considered as cervical cancer. Signs and symptoms of cervical cancer may vary depending on the extent of invasion. Small volume microscopic lesions are often asymptomatic and detected incidentally. Most cervical cancers are friable vascular masses on the cervix, and patients usually present with abnormal bleeding, typically postcoital bleeding, prolonged intermenstrual bleeding, and postmenopausal bleeding. Any woman with these symptoms should therefore undergo a pelvic examination. In more advanced cases, patient may also have the following symptoms: abdominal pain, urinary incontinence, anemia, and renal failure. Now let's discuss about the diagnosis of cervical cancer. Complete evaluation starts with Pap testing. Positive results in Pap test should prompt colposcopy and biopsies, including excisional procedures. Pap testing was originally introduced by Papanicolaou. In this test, a small brush is used to sample cells from the transformational zone and looked under the microscope after several preparations. For more than 95% of women, cervical cytology is normal. Testing for high-risk HPV increases the sensitivity of cervical screening. Therefore, nowadays many countries screen for high-risk HPV first, followed by cervical cytology. Colposcopy is the examination of the magnified cervix using a light source. It is used for both diagnosis and treatment. Application of acetic acid and iodine solutions highlights abnormal areas, as you can see in this picture. Because acetic acids gives a white color to the areas where there is high rate of cell proliferation. Imaging tests can be used to assess the distant spread of the cancer. MRI of the abdomen can be taken to look for local spread and lymphadenopathy. Chest X-rays are taken to assess lung metastasis. Finally, let's come to the treatment. Low-grade CIN regresses spontaneously in up to 60% of cases. Therefore, close follow-up with colposcopy and cytology is recommended for CIN-1. By contrast, high-grade CIN requires treatment with excision or ablation. This image shows a large loop excision of the transformational zone. For cervical cancer, surgery and radiotherapy are recommended, depending on the stage of the cancer.